Okay, thank you so much for having me. I am just really honored. It's a privilege to be here amongst my colleagues and friends to share with you something that I'm really passionate about and have been since I first encountered it. I'll get to that in a little bit. And I hope you come away today feeling a little bit more empowered. You know, we all know that lifestyle affects health. Devin, thanks for that great story. You probably tripled his lifespan too, just for that triple. What we sometimes miss, even though we know innately that lifestyle matters, is that unhealthy habits are actually critical when we reverse them to preventing and reversing chronic diseases. The same things we treat day in and day out as family physicians. And that idea seems really simple, but guiding patients through change sometimes isn't, especially given the limited time and training we have in our medical training around lifestyle counseling. So by the end of our time here together today, I really do hope that you come away thinking about lifestyle medicine as a first-line treatment. You can share with any patient at any stage of life, no matter what their disease is. And I hope to give you some practical tools that you can initiate in a busy office setting. And the best part is that it has zero side effects, unless you count feeling better as a side effect, which is one that I can certainly live with. I also want to say, I know we have a friend up there. I am all for time in nature, but if you start to see him like coming down, please like just give me a warning.
We're going to be running, so you'll get that.
I'll get the. Fair enough. He looks like he's really relaxing. His paws are like. Okay. So my session objectives today. The first part. So this will be in two parts. The first part could be a little bit longer than the second. The first part is the why, right? We're going to revisit the definition of health and identify our top causes of death in Canada and disease. We're going to talk about prevention in a little bit of a different framework. Then I'm going to go ahead and define lifestyle medicine and go over there's like tons of evidence, but I'm going to just choose two studies I'll kind of introduce you to for its role in prevention and treatment of chronic disease. I'll kind of touch on my journey, how I fell into lifestyle medicine or stumbled upon it. And then we'll overview the 6 pillars of lifestyle medicine. And in each pillar, I tried to think of some, what I call bang for your buck tips. Things that would really kind of hit home. The triple kind of, nuggets you could give in each pillar to try to make this as practical as possible. And then we'll take a bit of a mindful break, and I'll explain that when we get to it. And then the second part will reconvene, and we're going to talk about the how. So just again, some more practical tips. I call it the tips, putting theory into practice, where I'll go over how to have some conversations like this with patients about how to change behavior. And also I'll talk a little bit about some ways that you can incorporate it into your practice, and maybe some ways that might remunerate you a little bit better for doing this work. And then we'll have an interactive case study. I'm very honored that 2 of my former patients from my practice have come to share their story. They participated in a program I developed in my practice that they participated in, and I won't steal their thunder, but we'll hear their story, and then we'll have some time for Q&A. Sounds like a lot to get done, but we will get it done. My disclosure, I am receiving an honorarium for speaking at today's event, and I am affiliated with the Optimal You. It's not launched yet, it's an idea that we're bringing to the forefront, but it is a private medical clinic. I'm not looking for any referrals. I'm just here to tell you about lifestyle medicine. Okay, I always love to start my talks on lifestyle medicine with actually going back to basics and looking at what we actually define health is. And the World Health Organization actually defined health for us back in 1946 as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. In other words, health is much more than just not being sick. When I reflected on this definition against my own training in conventional medicine and even my early years of practice, I had to admit, most of what we do is not true health care. It's actually disease care, right? We spend a lot of time diagnosing and managing disease and illness after it appears, rather than helping patients achieve what we define as health. And constantly chasing disease, especially now, exhausting. And it's not just exhausting for us, it's also for our patients. And that's no wonder because chronic disease is everywhere. If we look in Canada, almost 90% of all deaths are caused by non-communicable diseases. And in 2023, cancer and cardiovascular disease alone, those two diseases claimed the lives of several 100,000 Canadians, respectively. And these numbers are not lowering. So it makes cancer and cardiovascular disease our top killer. Globally, cardiovascular disease is our top killer. And chronic diseases don't happen overnight, right? You don't just wake up one day with diabetes. They happen over years, sometimes decades. And sometimes it's out of a patient's control. There are some factors, right? Chronic diseases happen for a myriad of reasons. But most of what we're going to learn is most of what causes chronic diseases are actually in our control. This study here was published in 2013 in JAMA, and it looked at the root causes of death and disability in the US, which we can translate here to Canada. And what it found, I don't know if you can see, but diet and tobacco alone were the leading causes of death and disability. And the other bars include things like high blood pressure, high body mass index, high cholesterol, high sugars. So diet and tobacco were the leading killers independent of those other, conditions. And physical activity is also in there amongst the top 5 root causes of death. So studies subsequent to this show that 80% of chronic disease, at least 80%, is rooted in our lifestyle factors. So our lifestyle is killing us. And we know now that even if you have a genetic predisposition for disease, there is mounting evidence that lifestyle factors play a role in epigenetics. That is, whether genes turn on or off. So we have a saying in lifestyle medicine that genetics may load the gun, but lifestyle pulls the trigger. So as family physicians, it is drilled into us in our training that good family medicine is rooted in prevention. But somewhere along the way, I feel like we as a healthcare community have started to reduce preventative medicine to getting patients to do their fasting blood work, getting their mammograms, pap smears, colonoscopies, fit tests. And please don't misunderstand me. These tests are critical. They're very helpful in identifying disease, but that's just it. It's early disease identification, right? Testing for a disease and treating it earlier does save lives. I'm not going to argue that, but we're not actually stopping the disease from happening in the first place. We may be reducing deaths from these diseases by testing them earlier, but we're not stopping them. And in essence, we are, as physicians, like in this cartoon here, we're kind of mopping up the ever-presence of disease without really focusing on what turns off the tap. And we're not trained to do this. This is not our fault. We're just not trained to do this. But it stands to reason that if 80% of chronic disease is rooted in lifestyle, then real prevention doesn't happen in our office. It doesn't happen in the lab or the colonoscopy suite. Real prevention happens in a patient's home, in their lifestyles, day in and day out. Real prevention also happens when we as healthcare providers educate and empower patients with clear, evidence-based instruction on how to make changes to their daily lifestyle and habits, be it nutritionally, physically, mentally, and emotionally. When I think about what's missing from medicine, it's not more tests or newer drugs or fancy technology. What's missing is the time and space to really address the root causes of disease. We are excellent at managing downstream consequences. We adjust medications, we order scans, we do procedures, but we are not educated to, nor are we paid to, focus upstream where the diseases actually start and where health can be created. Our patients need education, they need skills, and they need support to help make meaningful changes in their lives. And just as importantly, we as physicians also need the same things. We need time. We need connection. We need permission to practice for ourselves the very lifestyle modifications that I'm suggesting we prescribe, right? So until we bring that back into healthcare, we will continue to provide disease care. And in 2020, the World Health Organization, this is mid-pandemic, they reported that while we've made huge progress against infectious diseases, we have made, quote, inadequate progress in preventing premature deaths from chronic disease. They called here for comprehensive strategies to meet global targets by 2030. Not that far away. And here's the reality. Medicine can mobilize quickly against acute threats, like COVID. We cut deaths during COVID dramatically in a matter of years. Yet globally, our chronic disease rates keep rising. Comprehensive does not mean complex. I am deeply grateful for modern medicine. I use it on a regular basis. But to truly avert the chronic disease that we see, and we're in crisis here with it, we need to address the missing link in chronic disease. And that link, I believe, is our lifestyle. So what is lifestyle medicine? Just to define it, the American College of Lifestyle Medicine, under which I got a board certification, is the therapeutic use of evidence-based lifestyle interventions to treat and prevent lifestyle-related diseases in a clinical setting. And it does this by empowering patients with the knowledge and the life skills to make effective behavior changes that address the root cause of chronic disease. Lifestyle medicine focuses upstream. And lifestyle medicine is built on 6 pillars. They're not rocket science. We have nutrition, physical activity, sleep, stress management, social connection, and avoiding risky substances. It's so simple. Yet what makes them so profound and powerful is that they're actually a one-size-fits-all recommendation. Because whether your patient has acne, GERD, diabetes, heart failure, any disease, any of the pillars apply. And the bonus is that many of these same choices also support planetary health. Because as Dr. David Katz, he's a lifestyle medicine physician in the US, says, there's no healthy population if we don't have a healthy planet to live on as well. And if you think that educating patients is a novel concept, it isn't actually. Centuries ago, Hippocrates, who we know as the good old father of family or conventional medicine, also recognized the importance of partnering with his patients for the best possible outcomes. And remember, he didn't have any fancy equipment. He just had his patients and their habits to work with. And he profoundly said, the greatest medicine of all is teaching people how not to need it. I think Hippocrates would have loved the branch of lifestyle medicine. Now, I want to emphasize that lifestyle medicine, and this is really key, I'm not suggesting in any way that lifestyle medicine should replace or dismiss conventional medicine. But the two really are optimal when they work in synchrony for health provision. As Dr. Mark Brayman's diagram shows, lifestyle medicine should be the foundation of a whole health treatment, not an afterthought or something we don't give emphasis to. And there's a place for each in healthcare, right? For conventional and lifestyle practices. Like, for example, if a patient walked into my office with chest pain and shortness of breath, I'm not going to sit down with him or her and meditate with them and suggest they eat more kale. Like, that would be ludicrous, right? I would give them 2 aspirin to chew, a spray of nitro, and get them as quickly as possible to the nearest angiography suite for a stent, right? Conventional medicine, pills and procedures, it shines in acute crisis. Thank goodness we have it. It saves lives when patients are unstable, and we absolutely need it. But when it comes to chronic disease, where lifestyle factors are the root cause, medications and procedures alone are not solving the problem. Because if they were, we would see declining rates with every advancement, right? But instead, what we're seeing on a global scale is chronic diseases, their rates are rising, and now what's scary is that we're seeing it present in younger and younger age groups, including our children. And so this is where lifestyle modification is foundational, because it actually gets to the root of the weed. Now, lifestyle prescriptions don't guarantee patients will never get sick, but they definitely swing the odds in their favor of a longer lifespan and a longer health span. And while lifestyle prescriptions don't eliminate the need for medications, we still need them in many cases, perhaps it means lower doses or one or two fewer medications, right, to treat the condition. There's always potential for benefit, and again, with no side effects, except people often feel better when they make change. And that's why I really feel the combination of lifestyle and conventional medicine together are really stronger than either one alone. Now, if lifestyle medicine is ideally meant to be part of optimal healthcare, I wish I could say I came out of my exceptional training at McMaster prepared to use it. But I wasn't prepared, and I wasn't aware. Not after my undergrad, not after my residency, not even in the first few years of my practice. What I did learn in detail was how to manage chronic disease with medications and procedures. And yes, I recall learning about chronic diseases in medical school and how to manage them. And then I recall under every treatment category there was this cryptic two-word line: lifestyle modifications. And then crickets, right? No explanation, no elaboration, no teaching or emphasis whatsoever on how to have these conversations with patients. And so those words just kind of got lost in the shuffle while medications and procedures kind of took center stage. And instead, I learned to use kind of blanket statements like, oh, keep your diet clean, like it's really pretty to clean diet, or try to get more exercise into your day. Little did I know how powerful those two words, lifestyle modification, really were in transforming patients with chronic disease. My journey into lifestyle medicine has been long and winding, and one really I only stumbled across because of a personal experience. So I'd like to introduce you to the man who introduced me to lifestyle medicine. It's not a patient. This is my late father, Albert. In fact, his birthday is today. He would have been 83. So cheers to you, Dad. My father, in 2005, a previously healthy man, didn't really see the doctor. He just had this cholesterol thing. He was diagnosed with stage 4 metastatic prostate cancer. He had no symptoms. He had a routine PSA, and he was literally blindsided when he finally saw his oncologist. I was in the room, and the oncologist said, listen, you have a very rarely aggressive form of your cancer, and you probably should get your affairs in order. We're looking at 6 to 12 months. I don't expect that the treatments are going to work against your particular cancer. I had never felt so powerless as a physician. Despite all my training, I felt like, oh my goodness, there's nothing I can do to fix this. But my dad was not an anxious man. I inherited my anxiety from my mother. But he looked at the oncologist and he said, okay, well, you're the doctor, but you're not in charge. He said, I'll take whatever treatments you recommend, but I probably have some work to do too, right? I don't even think I know where my prostate is, he said. I'm gonna do my research, you do you, I'll do me, and we'll let God, he'll handle the rest. And that's what he did. He went home, and he learned everything he could, not just about the type of cancer he had, but he started to look at what he could be doing. My dad never let my mother drive. He always wanted to drive the car. So he didn't want to let the physicians drive his care. He needed to take some control. So he started to research, and he took every conventional treatment offered to him. He had hormone therapy, he had radiation, he had chemotherapy twice, but he tolerated them with fewer side effects than expected. They worked longer than anyone predicted. And instead of 6 months or 12 months, my dad lived 12 vibrant, fulfilling years with end-stage cancer. Now, that experience was my first glimpse into just how powerful lifestyle change can be in chronic disease. And at first I thought, well, maybe this is a fluke. Maybe he got lucky, right? And then I started looking at the evidence. I started looking at what he was looking at. He was showing me studies by Dean Ornish, who did a lot of studies on prostate cancer and lifestyle modifications. And then I realized, oh my goodness, there is like solid medical evidence to back up the very things he was initiating. And it made me think of the words of American poet Maya Angelou. She said, do the best you can until you know better. But once you know better, you've got to do better. And once I saw the evidence, I could not unsee it or ignore it. And I knew I had to do better, not just for myself and my own family, my own life, but for my patients as well. And when I started to use it with my patients, I saw it work again and again and again. I was blown away, and I was sold. I would never turn back. And I used to get frustrated when the oncologists used to see him in his follow-ups, my dad, and then say, Albert, we don't know what you're doing, but it's working, so keep it up. Ha 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 ha. Like, I used to get frustrated because the truth is, we do know. We have known for years. Decades and decades of research confirm the very that lifestyle really does matter, and it should be the standard of care and part of our medical education. And that's why I'm so grateful to be here amongst you today, and to be given the chance to explain and to teach you a little bit about how chronic disease can be ameliorated with some simple lifestyle strategies. And we need a new tactic to win this war against chronic disease, and I do believe that that tactic is lifestyle medicine. Now, while my father's story is very inspiring, I do want to be clear, lifestyle medicine is not built on anecdotes or anecdotal stories. It's built, like I said, on decades of medical evidence, ranging from large observational studies to population cohort studies, also to gold standard randomized controlled trials. So much so that lifestyle modification, as you see, is embedded in pretty much every major guideline now for hypertension, diabetes, cardiovascular disease, obesity, and cancer, both in Canada and the US. And in most cases, it's recommended as a first-line therapy. Now, I could spend the rest of our time together and a few more days going over all the evidence, but I just want to highlight two studies that really started in my journey when I was looking into lifestyle medicine. They blew my mind. The first is the EPIC Potsdam study. It was published in 2009 in the Annals of Internal Medicine. It was a study that followed over 23,000 adults in Germany, in Potsdam, Germany, for 8 years. And the researchers looked at adherence to 4 relatively straightforward lifestyle habits, right? Not smoking, maintaining a healthy weight of less than 30, BMI of less than 30, basically not being obese, eating a healthy diet, which they defined as a diet that was high in fruits, vegetables, whole grains, and low amounts of lean meat or dairy, and then being physically active for at least 3.5 hours per week. And when they followed this cohort along, the patients who practiced all 4 lifestyle habits had a 93% lower risk of developing type 2 diabetes, 81% lower risk of heart attack, 50% lower risk of stroke, and 36% lower risk of cancer compared to those who adopted none of the habits. In short, 4 basic lifestyle choices cut chronic disease risk by more than half. And yes, these are relative risk reductions. I understand that. But the absolute numbers add up to hundreds of fewer cases of heart disease and diabetes alone per 100,000 people in just 8 years. On a population level, that is a massive impact. And to date, there is no single drug on the market that reduces your risk for diabetes, heart disease, stroke, and cancer simultaneously at the level seen in this study. The only intervention that has been shown to reduce all 4 conditions at once and so profoundly is lifestyle modification. What about randomized controlled trials? One of the landmark studies in lifestyle medicine is the Lifestyle Heart Trial published by Dean Ornish in 1998. So he took 48 patients with moderate to severe heart disease and he put them into 2 groups, he randomized them. The experimental group were put on a low-fat, whole food plant-based diet under instruction, aerobic exercise, stress management, smoking cessation, had group psychosocial support, and they were not prescribed a statin. The other group received a statin and usual care and advice from a physician. So they looked at the patients at 1 year and 5 years, and here's what they found. So first of all, cholesterol levels improved. At 1 year, it was actually more improved in the lifestyle group versus the statin. Then they probably increased the statin, so that by the end of 5 years, the cholesterol, the lowering of LDL was equivalent between the control and the experimental group. And this basically essentially shows that lifestyle change is as effective as a statin for lowering LDL cholesterol. I have seen this play out in practice. And as a side note, this very finding was also reinforced later by Dr. David Jenkins in his portfolio diet study, which demonstrated that statin level reductions in LDL cholesterol were equivalent to a statin using plant-based dietary pattern.
Can I ask if this was primary prevention or secondary prevention?
This was secondary prevention, so they had moderate to severe. They had no moderate to severe heart disease. Yeah. And even more profoundly, at 5 years, they looked at the vessels directly. Now, they didn't have CT angiogram technology yet at the time, but they used CT angiography. And what they found that those in the experimental group without statins had a 3.1% absolute reduction in coronary stenosis compared to baseline, while the control group, who were on statins and the usual care, had 11.8 absolute progression of their narrowing. So this trial was the first trial of its kind to demonstrate actual reversal of cardiovascular disease through intensive modification, lifestyle modification alone. And its findings have been corroborated by decades of research since, independent research since, showing that intensive lifestyle changes can actually reverse coronary artery disease. And so much so that the Ornish program is now covered and recognized by Medicare in the US, as well as other insurance providers. What's also remarkable is that Dr. Ornish postulated that the sickest patients would take the longest time and probably have the least amount of improvement, those who had the worst amount of stenosis initially. What he found surprised him. Regardless of their age, regardless of their symptoms, regardless of their disease severity, objective disease severity, those who committed most to changing their lifestyle saw the fastest and most dramatic reversal. And this lesson to me was very clear. It's never too late to initiate lifestyle modifications with your patients if they're willing to participate. So we have anecdotes, we have studies. What about at a population level? Does this play out? Does it hold up at a population level? Well, yes, it does. Has anybody ever heard of the Blue Zones? I'm sure maybe some of you have. There's a really great Netflix documentary you can watch. So Blue Zones, the studies of the Blue Zones give us further evidence that lifestyle does impact health and longevity at a population level. These are regions, for those of you who don't know, they're regions across the globe where people live the longest, healthiest lives. And people live, when I say they live a long life, they are living into their 80s, 90s, and 100 years, largely free of disease. And they live at a rate, they make that centenary rate at a 10 times higher rate versus the rest of the world. So they studied kind of like, are they doing things that, are there similarities? Even though they're vastly different populations, are there kind of common threads? And what they found was, yes, there were, and they call them the Power Nine. I won't go into them for the sake of time. But in these communities, basically, people eat naturally. They eat whole foods, a lot of plant, a lot of fiber, high fiber foods. They move throughout the day. Their environment is set up to do so. They stay socially connected. They manage their stress. They have stress, but they know how to manage it. And they live with a strong sense of purpose. And what's the result? These populations see lower rates of heart disease, cancer, and dementia, and decades of vitality. It is population level proof that lifestyle medicine works. And sadly, we're starting to see disappearance as a lot of these populations are getting, industrialized, and their habits are changing. So we're starting to lose some of our blue zones. So I also, before I get into the next piece, I do want to be clear. I firsthand understand how demanding family medicine is. And my goal is not to add more to your already extremely overloaded plates. I imagine for you that the idea of lengthy counseling about lifestyle change just isn't realistic. I understand. So in the second half of my talk, if you are interested in having conversations that help patients motivate change, I'll cover those strategies. But as I review the next 6 pillars, I just want you to, I want to highlight for you some quick, like strategies. So even in a busy office setting, one 30-second lifestyle nudge, you never know what it will do for a patient and how much they will take that advice and run with it. It's like all about planting seeds. I'm just asking you to consider planting seeds. I mean, we're on a farm-ish, so like it's a perfect place. So plant a seed because it can grow a beautiful outcome. And my hope is that you'll come away with some ideas and things that grab your attention in ways you can introduce each pillar that feel both practical and realistic for you. All right, well, I'm going to mention Hippocrates again. He's my bestie. He said it centuries ago, right? Food is medicine, right? Studies show that nutrition is foundational for well-being. What we fuel our bodies can either foster health or contribute to disease. And healthy eating, which emphasizes eating higher amounts of plant-based foods, so things like vegetables and fruits and beans, nuts and seeds and whole grains, and then eliminating processed, refined foods, and then reducing the amount of saturated fat and animal protein in your diet. These are also shown to be major culprits of chronic disease development. When we do that, we see better health outcomes. And in Canada, we are really fortunate that our revised 2019 guidelines just reflected this very pattern of eating. And I don't know if you know this, but Canada was they were cutting edge on this. They were the only country in the world, the first country, not the only now, but the first country in the world to base their guidelines 100% on evidence with zero industry input. That's pretty spectacular because that does not always happen in other guidelines. And they basically, when they looked at the science, this is what they came up with. And it's very easy to show a patient or explain to a patient because it's not based on the serving sizes and the rainbows anymore. You just look at your plate. Look at your plate. Try to make half of your plate starchy, non-starchy fruits or vegetables of any kind, of any sort. A quarter of your plate, choose whole grains. And then a quarter of your plate, instead of having meat and dairy and then alternatives, it just says a quarter of your plate should be protein, right? And the protein can come both from lean animal sources, but also from plant sources, and then making water your drink of choice. And when we eat this way, the studies show that we are much healthier. So, what are some BFYB? I keep wanting to say bring your own BYOB, but it's BFYB. When it comes to nutrition, what kind of things do you recommend? The top two things is getting patients or leading patients to unprocess their diet. That's huge. I think if we just did that alone, we would see such a dramatic drop in chronic disease. And then emphasizing fiber over any macronutrient you can. So the thing though, when it comes to unprocessing your diet, is that it's important to validate with your patients. It's hard to give things up that you like. And we're not trying to make you never eat them again. It's not a reality. But trying to reduce them as much as possible. And the goal is never perfection, it's always progress. But then take it one step further and give them ideas as to how to swap their cravings. So what I mean by that is, if patients have a really sweet tooth, it's really helpful, I've found, when I share a recipe with a patient. So you like Snickers bars, here's a trick. You get your patient to Google the words whole food, plant-based. I like to put oil-free, not because oils are necessarily bad, but it just weeds out things like that include vegan butters and things like that. You do whole food, plant-based, oil-free, blank. So I did this. I put Snickers bar, and tons come out, 6 ingredients, pretty quick. They look delicious, but it gives the patient something that they could try to, again, untrain their lit-up pleasure centers, because that's what happens. This processed food is formulated to hyper-stimulate their pleasure centers so that they don't even know what sweet is anymore. They just want to chase the dragon and eat more and more, sweeter every time. And so when you give them something to swap, it really helps. And in your handout package, which you'll be emailed later this week, I kind of curated one for salty and one for kind of savory snacks. You can, ideally email them because they have links. So I actually linked them to different recipes for different kinds of treats. But it's endless. The options are endless. I also, you're going to get a lot of stuff, I'm sorry, from my end, coming, but there's also a resource page that has a bunch of recipe websites that have a lot of really healthy plant-based options, but they really cover those cravings really nicely. Like, I love Plantable Kiki's work, and Plant You, she's Canadian. She wrote some great cookbooks. She's from Barrie, Ontario. So yes, get them to unprocessed, but you gotta give them something. Like, it's really helpful if you give them something to sub it in for. And just reinforce, this will take time. Not a lot of time, but it does take time. The first time you try the plant-based Snicker bar, no, it's not gonna taste like a Snickers bar, but over time, your brain will recalibrate. Stick with it. Stick with it for like 2 to 4 weeks. If you can do it for 2 to 4 weeks, you can see a difference. And honestly, 99% of the time, when they stick to it, it does change. And when they go back to eat a Snickers bar, they're like, oh my God, that was so sweet. So yeah, unprocessing is a big one. And then emphasizing fiber over any macronutrient. Really, fiber is like critical to our health. It's critical to feed our microbiome. And when you feed the microbiome fiber, it just releases all kinds of anti-inflammatory small chain fatty acids and chemical compounds that enhance our health and decrease inflammation. And so a simple message I like to give patients in a way of a quick kind of bang for your buck, I say add before you subtract. Don't focus on what you have to take away. I'm not telling you to eat less of anything, but could you pick another fruit or vegetable and eat it first in your meal? Add something, add more fiber to your plate and eat it first, and then whatever room you have left over for the rest of your meal, go for it, right? Because fiber is also satiating. So those are my 2 BFYBs for nutrition. By the way, I just want to make 2 points. We will have time for question and answer. So if you have any questions, write them down, and if we don't get them to today, in a week's time, I'm going to be hosting a 1-hour virtual lunch webinar to cover any questions you had, and also to show you some other things as well, for those of you still interested. And also, the other thing I want to say is feel free to stand up or get up at any point. It's a long time to sit. Actually, I'll be getting to that in my next slide shortly. So movement, second pillar, critical to health. And the Canadian Sports and Exercise Physiology Guidelines that we show here are a strong reminder of that. They just recently updated these, I think in 2024. Regular physical activity lowers the risk of heart disease, diabetes, and some cancers. It improves mental health, bone density, and basically makes you feel better. One of the largest studies to date, published in Circulation in 2022 and involving over 116 adults, showed that by simply meeting the guideline of 150 minutes of moderate activity per week, lowered all-cause mortality by 20 to 25%. And even more striking is that if you did 2 to 4 times that amount, you you had a 40% lower risk of dying from any cause and similar reductions in cardiovascular deaths. So the take-home message with movement is that the more we move, the better we do. Even modest amounts of regular activity can make a real difference. So what are some BFYB tips for this? 1, ask your patient. Because again, as Devin alluded to, if we're not asking them, A, we don't know what they're doing, but B, as a family doctor, when you bring it up, they listen. I know it doesn't seem like they're always listening to us, but like, they pay attention and they say, wow, this matters to my doctor. Maybe it should matter to me. So PAVS stands for Physical Activities of Vital Sign. So kind of treat it as a vital sign by asking 2 questions. 1, how many minutes of moderate to vigorous physical activity do you get each day? And moderate to vigorous, you got to define for your patient, because they may think that they're moving, but they're kind of moving, right? So moderate to vigorous, do the talk test. You tell them, are you moving? This means, are you moving at a pace that you can walk but not sing? That's moderate to vigorous. And then you say, how many times a week do you do this? And then you multiply it 1 by 2, and if it equals 150, high five, good job, encourage. You're actually dramatically reducing your risk of dying early and lowering your risk of disease. Keep it up, it's a great job. And if they're not, then you want to move to the second part, where you can suggest how can you move more. And I would use the word movement over exercise. I feel like some people get a little uncomfortable with the word exercise. So asking them, like, hey, is there a way that you could add more movement, on your, over time on your feet as part of your daily habits, right? Like, taking the stairs, or walking a bit further from your car, or like doing squats while you're kind of waiting, or a wall sit while you're waiting for your water to boil, for example, or brushing your teeth to like, I don't know, jumping jacks, right? There's little ways you can add that movement, asking them. See what they can come up with by asking them that open-ended question. The other thing, and it came up in the guidelines, is that standing. We say that sitting, thank you. Is my voice getting we can say sitting is the new smoking. It is true. Sitting for prolonged sitting is now recognized as an independent risk factor for early death, heart disease, and diabetes, even in patients who exercise. So patients who kind of work out at the gym in the morning and then sit for the rest of the day, the studies are actually showing that they also are increasing their risk of developing disease down the road. So the idea is to stand up. And one simple tip you can give to your patients, say, yeah, you know what? Sitting for a long time, if you have a desk job, get up once an hour. Just set a timer. There's even an app for this. It's called Stand Up, I think. Stand Up Timer. We've created an app for this. Once an hour, it'll get you up. 1 to 2 minutes. Just stand up, walk around, move around. Even that simple activity can add years to your life. And it seems very simple, but it does add up. And the final thing you can do is introduce the idea of movement snacks. So movement snacks are short bursts of activity. Even 1 to 2 minutes of vigorous movement, like climbing the stairs quickly or brisk walking to the car, everything counts. They call this VILPA, vigorous intermittent lifestyle physical activity. And when a 2022 study showed that even just 3 to 4 bouts of 1 to 2 minutes of this vigorous activity used in your day, like climbing the stairs briskly, it's been linked to a 40% reduction in all-cause and cancer mortality, and nearly a 50% reduction of cardiovascular mortality. And the beauty of VILPA is that it doesn't require any equipment or planning or even gym, nothing. You just use your body, and you can weave it directly into your day-to-day routines. And speaking of which, if you have an apple, I'm sure it's time to, everybody just stand up for a second. Just want to practice what we're preaching. Give a little stretch. Like those joints, right? It feels good to move, right? Yes. And you do not have to sit back down. You can sit back down, but standing up, if you want to stay standing for a little bit, this does not distract you if you're standing or if you're moving around. It honestly doesn't. Do what you need to do to move your body and initiate the very prescription that we're going to give to our patients. But I'll move on because we only have so much time together. So stand or sit is all up to you. No pressure to stay standing, by the way. I'm not judging anybody here. Okay. The next pillar is stress management. And it's a big one, right? Because stress is everywhere, right? But stress is a normal survival response. The problem is our brains do not distinguish between real threat and perceived threat. So whether you're being chased by a bear or you're being chased by your boss, it triggers the same flood of stress hormones in your body. But your brain cannot tell the difference. And we live in a world now where we can be bombarded with bad news 24/7. So we start to perceive our world around us as threatening. That's a problem because the fight or flight mechanism, which was supposed to protect you in times of real threat, is now being triggered 24/7. And that cascade of hormones completely disrupts homeostasis. Is that correct? I'm trying to
He's a stand. I think
He's
he's the official MLPCA.
Way to go, dude. You listen to my instructions. You can come back with me anytime.
He's smiling.
He's smiling, or he's ready to pounce. Speaking of stress, okay, chronic stress, it's linked to heart disease, it's linked to high blood pressure, weakened immunity, digestive problems, and mental health conditions. This Inter-Heart study, it looked at nearly 25,000 people across 52 countries, and it found that high psychosocial stress doubled the risk of heart attack, independent of other factors, and its findings were consistent across geography, age, sex, and socioeconomic status. Stress in this study also risk of stroke. So in lifestyle medicine, we emphasize tools like mindfulness and meditation, which I'm about to talk about, that activate the parasympathetic nervous system, and this counterbalance that constant state of sympathetic overdrive. So it's important to tell your patients and validate that stress is actually normal, right? To imagine that you're going to live a life without stress is like thinking about walking through water without getting wet. Life has stress in it, right? Our goal is not 24/7 bliss. But instead of avoiding stress or distracting from it, we can encourage patients to kind of lean in and be just uncomfortable for a few minutes. It's like a misbehaving toddler, right? When you get down on its level and you give it some attention and maybe even bring it in for an embrace, it begins to settle down. And this is the essence of mindfulness. It's about paying attention in the present moment and allow those thoughts and feelings to arise without trying to do anything about it, and getting curious and not judgmental when those feelings come up. And in doing so, we calm a very overactive sympathetic nervous system, and we begin to teach ourselves that we can cope with discomfort. Now, I need to say this, is it important? This does not apply to patients with PTSD or trauma. Those experiences do require the guidance of a trained medical professional. What I'm referring to is the patient who comes and they're like, I'm so stressed, like my job or my family or my kids or this or that, like I'm having problems with a friend. Those day-to-day stresses or that discomfort that arises from those day-to-day stresses, mindfulness works. And one activity you could teach, or you could share this link with the patients to take home, is called the RAIN exercise. I'm actually going to share the link with you. This is where I mess things up. Ready? This is my terrible technology skills. Is it this one? Yes. Okay. Maybe I won't mess it up. Okay, this is the RAIN exercise. It was created by Dr. Judson Brewer, or he modified it from somebody else who developed it. He's a psychiatrist in the US who does a lot of mindfulness for anxiety, but also for addictions. So here is the RAIN exercise you can share with the patient. Okay, so that's the RAIN exercise. Very simple, practical, tangible that your patient can employ. You can even make little cards that just, give to your patient that they could take home with them as a little cue card for what to do when that uncomfortable feeling of stress is kind of getting over your kind of spiraling. RAIN it, right? And then there's meditation. And regular meditation, I would start to prescribe it for your patient. And the reason is, studies have shown over time, regular meditative practice, up to 20, at least 20 minutes a day, so they have to work their way up to it, can actually restructure the brain. It has been shown by PET scans and functional MRI, sorry, not PET scans, functional MRI, to shrink the amygdala, which is your fight or flight center, and it actually increases the gray matter and density of your hippocampus, which is responsible for memory and learning, as well as the prefrontal cortex, which is responsible for executive functioning and decision making and self-control. In kids with ADHD, regular meditation, if you can get a child to regularly meditate, I mean, good luck if he has or she has ADHD, but you got to work with them. There's strategies you can do. It really does help because it actually grows those parts of executive functioning in your brain. And there's a free app. I have no shares in this app, but I use it myself. I've recommended it to patients. It has hundreds of free meditations called Insight Timer. When you get a copy of the slide, you'll be able to click on the link, and any of these links. And that app has like tons of different meditations for any kind of for anxiety, for sleep issues, for cancer patients. And what I love about it is you can choose it by time. So I wouldn't start for 20 minutes. I would have them start for even 1 or 2 minutes and then build it up slowly. And then for those who don't even have time for that, teaching somebody a regular micro reset. So 1 to 2 minutes of just breath work. And 2 activities is a box breathing. So telling your patients, okay, when you start to feel overwhelmed, take a deep breath, and then breathe in for 4 seconds, hold for 4 seconds, breathe out for 4 seconds, hold for 4 seconds. And doing about 5 of those cycles can again activate your PNS. Parasympathetic nervous system, PNS. For kids, if it's hard to imagine a box, teach them to trace their hand. Breathe in, out, in, out. So they can trace their hand forward and then back. And that, again, will help to settle down their sympathetic nervous drive. The next pillar is substance avoidance. No surprise here. We've known, for example, that tobacco and smoking remain leading causes of preventable death. An estimated 67,000 substance-related deaths in Canada per year. But lifestyle medicine takes a broader view as well, and addiction isn't limited only to chemicals, right? Patients can struggle with things like gambling, overeating, shopping, technology, social media, even work can become, a kind of crutch. And it's usually used to distract from discomfort. And by definition, addiction is a powerful urge to use something despite knowledge of harm, often because the brain has wired it to provide relief or reward. And that's why patients hold on, even when they know there's risks, because it's a biological survival response being inappropriately triggered. And addiction is complex and impossible to address in a short visit, but the role you can play as a family doctor in a short amount of time is just planting seeds of awareness, maybe creating a safe space for reflection, and then helping patients take first steps if and when they're ready. So there's a 5 A's model. It's a quick structured way to address addictions, especially if you have a bit more time. Simply asking a patient about substance use is very helpful. And then advising, but clearly and firmly about did you know? So for example, we have new alcohol use guidelines in Canada released 2 years ago now, maybe a year and a half ago. And a lot of patients don't know this. They still think they're allowed that 7 to 10 drinks per week. And really the lowest, safest amount of alcohol is 0 in terms of cancer prevention. But maybe that's not realistic, so then say, okay, if you want to keep your risk for cancer, and people don't know that alcohol is actually a toxin linked to cancers, things like breast and colorectal cancer, and so you want to keep it to less than 2 standard drinks per week. And showing them, perhaps, having this posted in your office somewhere, or pulling up the handout to show them as a diagram, we do know, this is how you advise a patient about the risks. You use different tools that they have on the CAMH website. And then you want to assess their willingness to quit. A simple question might be are you interested in cutting back? And if they're open, then we go to, assist and arrange. And if they're not, you want to also remember that planting a seed is not just about opening a door and then closing it shut if they say no. It's just leaving it open and just saying things like, well, that's okay. If many people aren't ready right now or right away, but if you ever decide that you might want to change, there are resources we can help you with. Please come back and revisit this with me. And I might ask you again in the future if that's okay, just because, it's important. So under the assist, a next kind of bang for your buck tips. When you have someone who's like, yeah, I do want to lower, but I don't even know how to smoke less, or I don't even know how to take less alcohol or cut my social media use back. First is asking them to track their triggers, even just starting with that. Every time you have an urge to do X, Y, or Z, write it down. What's going on that's making you want that relief? And write it down so that they have a pattern to see their map. And then urge surfing, you can kind of use the RAIN acronym we just used for an urge. So if an urge comes for a craving, have them use the RAIN exercise to kind of relax into the urge. And even just trying to create that space between urge and action helps to break that habit loop. So even if you can distract them from jumping to using or smoking a cigarette right when they get the urge, giving that little space weakens that habit loop. If they are a digitally inclined patient who likes apps, Dr. Brewer does have apps. They're paid apps. Again, I have no affiliation with him. I just think they work. He actually has a 5 times higher smoking cessation success rate with his app. And the app is called Craving to Quit. There's a fee. You can buy a block fee for 3 months or 6 months, and he goes through daily mindfulness exercises to get people to be aware of their triggers, and then aware of while they're using it, what is it feeling like in my body? Eat Right Now is for patients who struggle with overeating, and he also has one for anxiety, because he says anxiety is a habit loop. That was mind-blowing to me, because he said at the heart of anxiety is fear, and fear feels worse than anxiety than worry. In the hierarchy of what feels uncomfortable. And so we use worry as a habit to do something about this uncomfortable feeling of fear. I never thought about worry that way. As a worrier, I really found it helpful myself. And I've actually used the Unwinding Anxiety app. It was amazing. And then, I don't know why I have number 1 for all of them. I just realized. Anyhow, the other thing is, if there's nothing else, if you don't have any time for anything else, just mention harm reduction. What can you do to maybe drink a little less? And here, the CCSA has a lot of patient handouts like this one, and just say, listen, we know that you're drinking 10 drinks per week. We know that your lowest rate or your lowest risk is less than 2, and just like Devin said, like you don't just start there. Don't go right down to 2, but can you consume a half a drink less a day? And see where that goes, and beat your target. And then, handouts like these give you other suggestions that patients can use to get there, to meet their new target. But making emphasis that any little bit of reduction is better than none. On to pillars. Sleep. Yes, sleep has not surprisingly earned its place as one of the 6 pillars. And what I've learned for both research and for my own life is when I learned about sleep, it completely shifted the way I think about it. And sleep, by the way, is probably one of the pillars that us physicians are notorious for neglecting. We're actually trained in a model that fosters sleep deprivation, and I was no exception. For years, I sacrificed sleep for productivity and getting myself caught up and kept up. I did obstetrics as part of my practice, so that kept me up. And at the ripe old age of 28, I developed hypertension, even though I was a lifelong runner, a plant-based eater. I never smoked, and I don't drink. I developed hypertension, and I have maybe a genetic predisposition, but I'm pretty sure I turned that switch on with the amount of sleep deprivation I did to myself over the years. But chronic sleep deprivation, in my opinion, is probably one of the most underrated health hazards of the 21st century, because it's pretty easy to stay awake these days. Studies show that sleeping less than 6 hours a night increases our risk of cancer, cardiovascular disease, and dementia, and it raises the risk of early death by about 12%. It can shorten your life expectancy by 2 to 5 years. But in contrast, good sleep can add 5 to 7 years to your life. And that's because sleep is when our brain and body does cleanup, right? This is when we repair tissue, we get rid of old abnormal cells, It's when we consolidate our memory, when we even lengthen our telomeres when we sleep, and that keeps us alive longer. So, we know now, and the IARC has classed shift work, night shift work, as a class 2A carcinogen. And no wonder, because this is when our bodies clean house, and if we're shortening that time, we're not getting rid of those abnormal cells. So sleep is not a luxury, it's a cornerstone for health and longevity. So if there's one thing you want to do with your patient is just make them aware of it, because I didn't think about it for myself, so how are my patients supposed to know? Making that connection that, are you getting enough sleep? It really is important for your health and for your longevity. Because if the patients are not hearing that from us, they may not hear it anywhere, and they may not connect their poor sleep habits to poor health. So it's important for us to bring that awareness to light. And ideally, they want to get 68 hours on average. So for some people, it's about they are staying up late to get things done, and that's where they might be able to fall into this. But what about the patients, and we all have them, who can't sleep? I want to get to sleep, but I can't. I have insomnia. This is where some bang for your buck tips around sleep hygiene really can make a difference. One, even more than the number of hours of sleep, is consistency in when you go to bed and when you wake up. Going to bed and around the same time, waking up around the same time, actually really grounds your body's clock, your circadian rhythm. It improves your sleep quality, and it helps prevent insomnia. And the second most important thing they can do is get morning sunlight exposure. Within 1 hour of waking, getting outside for even 20 minutes helps ground your circadian clock, and it actually boosts your melatonin production when it should be boosted at night. And then the third is caffeine and alcohol, so stimulants and depressants. Caffeine has a half-life of about 5 hours, so if you're drinking it after 2 p.m., it's probably still in your system. And of course, if you don't have a problem sleeping, if you can fall asleep and you drink coffee, go, that's fine, no problem. But if you have insomnia, I'd recommend trying to, again, eliminate coffee, but if you can't, switch to decaf or do even half calf, like half coffee, like half caffeinated, half decaf, and ideally not after 2 p.m. And then alcohol, people say, well, I use it as a nightcap, it helps me relax, it helps me fall asleep. Yes, it does make you fall asleep faster, it's a depressant. But it is very disruptive to your REM sleep and your deep sleep, so you actually wake up feeling less restored. And if you consume an evening drink and you have issues sleeping, then asking them, try and cut it out and see what happens. On an anecdote for myself, I used to wake up during the night, and I just thought, well, it's perimenopause, and that's supposed to happen. I don't drink a whole lot of coffee or alcohol, but I initiated consistency. I started to put consistency in going to bed and waking up at the same time. And I started getting out for a 20-minute walk every day, and I started sleeping through the night. I couldn't believe it. I wear a tracker, and my sleep score went through the roof. I honestly thought, wow, this actually made a difference for me too. It's something I didn't think I had control over as I got older. Some other quick bang for your buck tips is, telling them the environment matters. If you're trying to sleep in a hot environment, it's not going to work. So you want your environment to be cool, dark, quiet, or some people say it's too quiet. A white noise machine works wonders, or you can do it on your phone, but make sure the phone is plugged in off the other side of the room, because this will keep you up. That's what I mean for point 2. Digital sunset. People have trouble falling asleep. Try getting off a blue screen an hour before you go to sleep. And then if you have a patient who has obesity, hypertension, AFib, a history of stroke, diabetes, or they complain of daytime fatigue, screen for sleep apnea. I do a lot of work in the OR, and it is shocking how many patients are apneic during the procedures when they're sedated a bit, and they were not ever tested, or have they, been tested. And so just screening, stop bang, or just asking, stopping is most validated.
I know we're waiting to the end for questions.
Sure, yeah.
And I think a lot of us are thinking, could I just have a PDF that I could then send to my patients on each of these pillars so that I don't have to explain this each time?
Yes.
And I was wondering if a part of our plan is to circulate, if there are handouts available.
Oh, there are handouts coming to you.
And this is what I'm wondering, because we're all taking, I'm wanting to take a picture of everything,
Yeah.
but the amount of inaction that comes from that, the ability to circulate that to our patients really easily
Yeah.
is.
Yeah, Michelle is going to be, well, she already has been bombarded with a big package. It's all going to be sent digitally, mostly because if you have the ability, I don't know if you have the ability to email the patients, then they can click on the links. It's great. Otherwise, they'll just have to do the old-fashioned way and type in the links for each. But yeah, it's very comprehensive, including a lot of handouts. One of the best things I can recommend is making a free account with the ACLM, the American College of Lifestyle Medicine. There are tons of free resources for patients, one on each pillar. You can print off in hand. I still recommend, though, it's not just, hey, you need to work on your sleep, read this. I would still take 1 to 2 minutes to say, listen, this really matters. Even having some stats, just go back through my presentation, get some stats that you can give a patient to say, listen, this is how much it makes an impact, and then give the handout. It really does work. We're on to the last pillar. I know I've been here too long. Maybe not too long, but long enough for you. So our last one is social connectedness. And before COVID, this might have surprised people as being amongst the pillars, but the pandemic made it very clear that social isolation has serious consequences for both mental and physical health. There was extensive research by Holt Lundstad and all, and he included a meta-analysis of over 3 million people. And it showed that social isolation, independent of other risk factors, increased your risk of death by about 30%. Now, this is similar to, or worse than, smoking, obesity, or inactivity. On the flip side, social connection is one of the strongest predictors of longevity. When we look back at our blue zones, of those Power 9, 4 of them, key habits involve maintaining strong social supports and a sense of belonging. So in lifestyle medicine, we emphasize relationships as critical for vitality and longevity. And when it comes to behavior change, having a partner or support person also really helps. So when you're initiating behavior change, asking them to have a buddy really helps because A, it's accountability, but B, it's also social connection. So bang for your buck. Okay, one is screening for it, asking the question. This could be a loaded question, so if you're really pressed for time, it might get you into some problems, I'm not gonna lie. But if you get a sense, it could make a huge difference. Do you feel lonely often? If the answer is no, high five, that's great. But if it's yes, then just say, I'm really sorry. Maybe we can think of a way to work on this. And then maybe recommend one of these things for your buck. So one is encouraging small daily acts of connection. Asking them, is there any way that you have, you can reach out to somebody else, whether it's a text or a video call, or could you visit a friend or family member? Ideally once a day, but even if it's a few times a week, right? Having some regular touch points. Prescribing connection, and a way to ask this might be, what's one small way you can connect with someone this week? Can you think of any way you can connect with somebody? And thinking of things like sharing a meal. Is there someone, or do they belong to a faith group where they have regular meals? Can they move with a buddy? Do they have a neighbor who they see walking the dog? Could you say, hey, could I walk with you for 10 minutes in the morning? Joining a local group or a class. Eating, moving, giving, volunteering is another big one, especially for older adults. Working at Oakville, working at West Lincoln, 2 major hospitals, I see a majority of the volunteers are over 65, and it's heartwarming because it gives them a sense of belonging, and it gives them a purpose, right? It gives them reasons to get out and out of their house when they may not otherwise. And then for those who are rural, disabled, housebound, this is where technology can be beneficial. Whether that's online groups or video calls with loved ones. The bottom line is, connection, regular connection is important, and I'm not saying it's easy, but it does matter. And exploring ways that your patient can do that is very beneficial. And I also want to mention our marginalized patients. I'm not suggesting that this is always easy. Social connection can look very different, and it often, in marginalized patients can require some extra sensitivity on our part. One of the most powerful steps is to try and connect them with safe, culturally relevant spaces, community spaces, spaces where a sense of belonging is fostered and loneliness is therefore reduced. A practical resource you can use, I don't know if you know about it, is 211 Ontario. It is a comprehensive free 24/7 service that links people to local community programs. So they can either call 211 on the phone, or if they have access to the net, they can search 211ontario.ca, and it brings you up, and it has you enter your city or your region, and then by region it has more marginalized populations. And it really can connect them and give them a place to kind of seek out for more inclusive contact. Also peer and support group programs. If you have, say, a patient struggling with grief, connecting them to your palliative care team if you have a palliative care unit, and doing grief groups, or people who are struggling in a certain area. If there's a support group in that area, sharing a lived experience and being with people in that same lived experience doesn't solve the problem, but it can make somebody feel very much not alone in their situation. And then again, volunteering, even for our marginalized patients, asking if they had any interest in volunteering, it kind of shifts their perspective. They no longer become the client, they become the contributor, and that gives, again, a sense of purpose, which can help. And finally, it's important to acknowledge that connection can feel very risky for some people. And so in those patients, just you being there and sitting with them and holding space for them, even for 5 or 10 minutes, is offering its healing in and of its own right. And you encourage them to start with what feels safe, and that helps to build trust. I don't want to spend a lot more time because I want to give us time for a break. The unofficial pillar, time and nature, it's coming. The American College is going to, the word is they're going to restructure it to have a 7th pillar, which is time and nature. It's sad that we have to make this really that's sad. But 90% of Canadians and Americans spend 90% of their time indoors. And we're seeing the toll this takes, especially on our children. And so, emerging research shows that being outdoors, it reduces stress, it improves mood, boosts immunity, it even supports better sleep. So it's really important to recommend it. And one practical way is this was developed by Rachel Hopman at Northeastern University. She mapped this out in a framework called the 25-3 rule. So have your patients say, listen, if you can get outside for 20 minutes, and outside just means like outside your building, wherever there's trees or grass. It doesn't have to be in the wild. For 20 minutes, maybe during your lunch break, device-free is important. This really does benefit you. So 20 minutes, 3 times a week, get out in green space. 5 hours per month, can you get in a more natural setting, like a forest, a beach, or a trail, or fishing, or maybe take a blanket and be outside. Just be in a more kind of, go on a hike. We're so lucky in Niagara, and I'm sure we have it. Your trails are amazing, right? Getting out, just 5 hours per month, so it doesn't have to be all at once. And then she recommends for optimal health, 3 days per year getting completely unplugged, like middle of nowhere, off the grid, 3 days per year. That's the one I have the hardest time with, because I always feel like it makes me anxious to be like not connected in case there was an emergency. But I'm a catastrophizer, so that's probably why. So that's your VOIFBs for time and nature. So the last kind of point I want to leave you with is that all 6 pillars matter equally. We are it's really easy and natural for us to think of diet and exercise first, right? Like it's the first thing that comes to mind when you think about lifestyle, at least it was for me. But they all matter. And even if one is neglected, disease can develop, right? And so if you're not sure where to start with your patient, I'll have a handout listing all the 6 pillars, present the cornucopia of 6 pillars and say, hey, which one is speaking to you? Is there one that you'd like to start with? Then emphasize how important that is. That's a great start. And then you give a handout on that pillar from the ACLM. That's a really good kind of strategy you can use. One pillar usually stands out for a patient above others, so focus on that with them. Okay, so I think it's time for a mindful break. And don't go far, because I do want you to come back. Or not, it's up to you. Autonomy is important. But I'm going to encourage you to take a mindful break. Whatever you choose to do in the next, be back in 10 minutes. So set a timer for 10 minutes so that you're making your way back, so we can restart promptly. Whatever you choose to do. If you're going back to have a snack, use as many senses as you can, right? If you're pouring a coffee, feel the coffee in your hand. Smell the coffee, take a good breath. See what it does to your body. Oh, my mouth is watering. Oh, I'm getting stimulated just thinking about my coffee. Take that first sip, and then feel it. Just be mindful. You go outside, feel the sun on your face, and listen for sounds of nature, right? 10 minutes of just a quick mindful snack, and then